I hope that I am going live to you. Welcome to Facebook Friday. I am filling in for our lovely Kate, who is having a very, very, very well-deserved break, as you all know. So I thought I would come in and just fill you in on a few things. But firstly, I'd just like to recognise where I come from in this part of the world. So I live on the Mornington Peninsula, a very, very beautiful place. And I just wanted to recognise the traditional landowners, the Bunurong people, who uh, have been, the traditional owners of this beautiful land that we nestle between the ocean and the bay. And I would like to pay my respects to their elders, past, present, and emerging. So I would like to do a bit of a shout out also to our Victorian friends. This is quite a difficult time, as it is a difficult time for all Australians, but we are now in, gosh, week whatever. I don't even think we even know what week we're in relation to our stage 3, stage 4. And I know it has been really difficult. And I just doing a shout out to everybody to say, keep smiling. We'll get through it. I won't use any of those catchphrases that we're all doing because let's face it, we're all a bit over it. But I think, look, I just wanted to update you on just some of the things that we're doing this week and what's been occupying our time here at Neuroendocrine Cancer HQ. So one of the things, and I guess it's completely COVID related, and I know Kate's been doing some real COVID updates, especially with regards to wearing masks but I think I'd like to just do a bit more of an update around getting access to treatments. So this has been a really difficult time, especially for our patients who go and travel interstate for treatment. Just this week, we had a meeting with our Tasmanian oncologists, as well as our friends here at Peter MacCallum, because you may or may not know, Tasmanian patients travel to Peter Mac for peptide receptor radionuclide therapy. So that's been obviously incredibly difficult trying to get into Victoria, and obviously then also going home, and the quarantine and isolation exemptions that we've been trying to do. So I just wanted to let our Tasmanian friends know that we are absolutely all working collaboratively with the specialists both in Tasmania and Victoria. We have drafted a letter to send to government to try and get these exemptions in place for our Tassie patients. I want to also, and those exemptions are actually more about the isolating back at home, so that you don't have to isolate in hotels. But I also wanted to reassure the patients travelling to Victoria or to Peter Mac that, very strict protocols are being put in place. And I live in an area where there's no cases, but we are still considered in Metro Melbourne. So I just wanted to, reassure patients that it is still safe to travel, it is still safe to get your treatment. And, I think more so than ever, these strict protocols are being put in place. So we will do everything we can to advocate for you at a government level to try and get that access. But please also email me or message me if you are finding any issues, not just for our Tasmanian patients, but across the board, because these are things that we really need to know about. We're also working with Cancer Council Australia to try and alleviate some of these real issues that patients are facing, trying to get across borders. One of the other things that we've been working on, and I'll talk a bit more next week, so you've got me for 3 weeks, is our WA petition that we will be launching. And I won't talk too much about that because it's just the writing's just been finalised. But what we're really trying to advocate there is for additional support services for our friends in Western Australia, and also trying to recognise one of the hospitals so that we can actually really improve the referral pathways for our patients, and that will increase their care as well. So I would like to think that I will be able to launch that next Friday for our WA patients to be signing. Unfortunately, I'm sure all our Australian patients would love to sign that petition, but to be recognised and put into Parliament, lodged into Parliament, it can only be WA residents, which is a bit unfortunate. I think some of our friends would remember when we did a big national one and we took that to federal Parliament as well. So we don't mind a petition if they actually get the results that we're after. And we really hope that will be the case in WA as we engage with the health minister there and many of the other politicians across both parties. We've got a few things that we're talking about with the upcoming World Net Cancer Day on November 10, and this week you would notice that it's the inaugural Para Awareness Week. So this is the first time, led by our friends over in the US, that they're trying to raise awareness around Paras. And we've been in doing some social media around that, but we're really going to be pushing the whole concept of earlier diagnosis with regards to what our plans are for World Net Cancer Day this year. It'll be a different thing. You know, we've had such wonderful times with our cafes and coffee cups, but that won't be what we'll be doing this year. We'll be trying to do a bit more of an online awareness, but I think it'll be really fun, and that will also be led by our newest team member. So we've had a few changes here uh, at the organisation. So unfortunately, we said goodbye to two of our members, Megan and Deanne. However, we are saying hello to Adi, who I'll introduce you more to. But if you all subscribe to the e-news, you'll see that we've written a piece there about who's who in the zoo. And Adi will be really helping us with a lot of the marketing and awareness that we'll be doing around World Net Cancer Day, as Meredith, who is our project officer, is really, really helping us with regards to healthcare professional education and research that we do as well. So we're all working exceptionally hard across all the different areas of the organisation. And as I mentioned, Meredith is working very hard on our soon to be launched, which again, I'm really looking forward to. And I really will need all your help with getting the word out, is our GP education modules. So these were the result of a survey that you all probably dobbed in your GPs to participate in, and we are working with the RACGP, the Royal Academy of College of General Practitioners, in an accredited online module, the first of its kind, and we hope to launch that in early October and hope to get as many GPs signed up to that as possible so that they are fully informed and educated about you know, obviously symptoms, but also the management and the long-term management of our beautiful patients that we want them to be part of our care plan and part of our care team a lot more. And I know that, you know, there's such a huge reliance on GPs. So watch this space. I know that I will hope to get Meredith in a few weeks' time when we're ready to launch that, which is being currently reviewed. And that's the other one of the big projects that we're doing, which we hope to really probably do another Facebook Friday on at some stage, is we have the Neuroendocrine National Tumor Registry up and running now in 5 states. And what we really will be pushing as part again of how we can bring you guys in is around the patient app, and you guys actually filling in some of your quality of life. And I guess that leads into some of the things I wanted to talk about today, and that is, you know, one, a big, massive thank you for always putting your hand up, for filling out our surveys, for participating in so much of the research that we do. And I wanted to assure you that the time that you spend doing that is absolutely time well spent, because we do a lot with that. So recently, I know the most recent one we asked you to help with was the getting results. And we're actually and thank you so much. I think we had over 120 responses, which was fantastic, especially for a survey that was about 30 questions. Um, But what we'll be using that is really pushing for a better streamlined process and trying to diminish that scanxiety that we face. But that will also really just lead into some of the other better outcomes and care way that we actually care for patients or the healthcare, and feeding that bit back to healthcare professionals so that they can use this information to better work with you. The other things that we've done, I know that we did a clinical trials survey over Christmas, which was, and again, thank you so much for those who participated. That was really informative to tell us how you would like to know about clinical trials when they do come up, and how we can better, promote those and recruit to those. And one of the big ones also that we did last year, and I've just put the story up on more, I think we did promote it, but I wanted to go through it with it in a bit more detail, was the economic impact of neuroendocrine tumours on our Australian patients. So this was a study that hadn't been done before. Definitely not to the point of what the impact was on patients. There has been studies in America and elsewhere about the impact on the healthcare system, because we know that patients are present and go to and use the healthcare system quite probably a lot more than potentially other cancer streams. So what we were more interested in is what the impact is on our patients, and what and how that actually affects the quality of life of our patients long term. So this was a study that was actually conducted at the hospitals, as well as promoted through what was the Unicom Foundation, now Neuroendocrine Cancer Australia. I've got to try and remember that all the time. And it was led by the team out of Royal Brisbane, with David Wild and Louisa Gordon, and also we had Royal North Shore and Peter McCallum involved as well. So from that study, I thought I'd just sort of highlight some of the things, and I know that this is very, very topical, and I see a lot in the Facebook group around costs. With particular things, and I guess I'm not probably telling you anything you don't know, but the good thing is that we can use this publication to try and take it to government, most importantly, to try and change some policies around your care. So just starting with, as I mentioned, over 200 patients actually participated in this, and we also were able to access Medicare data, which was really important as well. A staggering 44% of our patients retired early due to having a neuroendocrine cancer, which is a really, really high proportion. And I think that just even starting at that point shows the impact of having this cancer has on people's lives. So, and from that also, 1/3 of our patients also reported that they had to decrease hours quite dramatically. And it also impacted our patients from actually being able to, put their hands forward for promotions or looking for, other jobs, and it really impacted that. So automatically our patients are on the back foot, just due to the fact that it does impact them and their working lives so much. Only recently we videoed some patients for our GP modules, and thank you to those patients who participated in that. And it was very much a theme for one of our patients there, in that they had just landed their dream job, and unfortunately once they got the diagnosis of a neuroendocrine cancer, they had to pretty much give up that dream job and support 4 children along the way, 4 young children. So this is really something that we need to be able to really try and push and see what sort of avenues that we can get there in relation to support, or at least looking at the costs and the high costs that our patients face. I know that the conversations recently have been around chromogranin A, our blood tests, and that is definitely something that I will talk to you about what we're doing in that space. but also the other scans such as our PET and MRIs. Um, the highest costs reported by the patients were medical tests, obviously, travel, especially for our regional patients. And again, we're looking at how we can try and decrease those costs for our regional patients, and also specialist visits. There was also a really huge disparity between private and public, and I know that Kate has spoken to this quite a lot as well. We are a country of people who do like to have private health insurance, but we did see in this, and it was probably confirmed what we already knew, is that having working in the private system with neuroendocrine cancer can actually result in higher costs for our patients. Um, as I mentioned, 30% of our patients also reported that the PET scans and the MRIs were the most costly and the biggest out-of-pocket costs to their care. So we've done that extensively, looking at how we can get reimbursed here. We did have some success with pancreatic nets and what is called, so we have the Pharmaceutical Benefits Advisory Committee that reimburses the drugs, and then you have MSAC that actually reimburses the scanning and diagnostics. So we did have some success actually getting reimbursement from the old octreotide scans to now the gallium PET scans. But what we've actually, we only had, never do we get the full success that we want. And it was only what they call it an indication or a reimbursement for pancreatic net. So we know that there's a whole range of our patient population that needs to get access to those, what is a gold standard test, that we need to increase the ability for that reimbursement across the board. And again, looking at the disparity between private and public, we know that patients potentially in private have to pay $800 out of pocket, but if patients are seen in the public system, they're sometimes never out of pocket. So how can we actually make that a bit more consistent as well? As I mentioned, rural patients really around the high costs of travel to these, what we call centre of excellence. And centre of excellence are so incredibly important for our patients because it means that we have all the treatments available, all the diagnostic tests that are available, all the specialists across the different specialties such as surgery, endocrinology, nuclear med, oncology, that they all talk together. But we also realise that these centres of excellence are in these metro cities, so Melbourne, Brisbane, Adelaide, Sydney and Perth, and that's not helpful to all our rural patients. So what can we do to try and ease that? And I guess, again, COVID has really pushed this forward. And one of the things we've probably pushed for a lot in the past is telehealth. Um, I think it's been implemented very quickly because it needed to be. They're not without its problems, I believe. But in saying that, what we are really still trying to push forward is that it stays, that it does, but it stays in a a proper framework, and there's the best protocols put in place as well, so that for our patients, they don't need to necessarily travel just to get an update on something that can be delivered over the computer, because that would save hours of travel, anxiety, but also sometimes overnight stays as well. So there needs to be some discretion used, absolutely, in what information is delivered that way. But if it is something that can be done, I think that would make life a lot easier. Um, the other thing that we really want to put in place for our regional patients, and this will form part of the discussion in a minute, is looking at these shared care models. So where our centres of excellence in the metro city work with the local oncologists to either upskill these oncologists in what neuroendocrine cancers are, to really make sure that the GPs are also part of this shared care plan, to try and just minimize again the need for travel when these some of these appointments could be done closer to home. And we know that that would obviously relieve a lot of stress, and so much better to be with your family and friends in your local community rather than trying to travel all the time to the bigger centres. So we want to work out on how that can actually work better. Um, an interesting thing, and I guess again, it probably makes us a bit annoyed, but makes us again more determined, is when it was analysed the average cost, and this is the average cost for patients over a 2-year period for across those things such as travel and special tests and that sort of thing. The average cost for neuroendocrine cancer patients was around $6,000. Some patients reported up to $24,000 over that time, which is exorbitant and very unsustainable. Similar studies that looked at prostate cancer, breast cancer, melanoma, the average cost was half of that for that 2-year at only $3,000. So again, that makes us more determined. It's not probably very surprising, but it makes us more determined and gives us a good argument to try and level that playing field for our patients. So what does that mean for you, and what does that mean for your out of pocket, especially around the chromogranin A, the MRIs, and the gallium PET scans? Because I've spoken a bit about how we're trying to reduce the cost for the travel. So this year we're working very hard on a national framework. So this earlier this year there was one that was launched for pancreatic cancer. Last year, oh no, there's recently again there was another framework launched for ovarian cancer, and there was also the rare disease framework put in place. And what these national frameworks set to do is make sure that we have the optimal care plans for our patients. We present the cost of having these cancers, but we also try and encourage more research in it. So we're calling our framework the National Net Framework 2025. And I know that seems so far off, but this is where we will be launching in 2021. So we will be getting together all our stakeholders, so from patients to healthcare professionals, specialists, including GPs. We also want the pharmaceutical companies at the table, as well as the diagnostic companies as well, and our researchers, and everyone at the table, and obviously government, to work towards this plan, to highlight what the issues are, but most importantly, to come up with solutions as well. One of the things that we've been really speaking about within our Planet Registry Committee, who are a very, very engaged group of clinicians that I think most of you would know who those clinicians are, you all see them, is looking at a national funding framework, especially for peptide receptor radionuclide therapy, and trying to ensure that patients can always get access. We've heard, even just because of COVID, that some of the supply chains have been affected, especially for lutetium, as that often comes from overseas. So how can we work with ANSTO here in Australia to really ensure that they can produce as much as we actually need? So that will form part of that. But the other, what we're doing is the cost, as I mentioned, the cost of NET. So we're looking at the Medicare out-of-pocket costs and putting an argument forward to government to reimburse the whole lot of this chromogranin A, the MRIs, the gallium PET. And we also know that, by doing so, our patients are going to be more active within the community. They're going to have the ability to potentially stay in employment, and not absolutely eat into their savings, their superannuation, or anything that is never ever of any advantage to anyone. And unfortunately, we have to put it in these terms to government because it's of no benefit to them when people will then have to rely on, um, pensions and that sort of thing. So one of the so as well as all of that, as part of the framework, one of the key things, and it is in our tagline, is around earlier diagnosis. And I was really interested to see recently the discussion around some of the symptoms and how patients were actually diagnosed. So please always keep them going because we do read them. I'm always reading through all the posts, and I don't want to interfere too much in it, but I do really appreciate the sharing of this information. And the earlier diagnosis is absolutely key. We know if on average patients, it's taking 5 years to be diagnosed, that is huge costs of going repeatedly back into GPs, potentially repeatedly back into emergency departments. Um, Also, I mean, just and taking time off work, everything that goes with a delayed diagnosis is something that we're trying to work better on. So one of those things is obviously um, educating GPs around what are the symptoms to look for. As I say, it's neuroendocrine cancer is the cancer that no one knows about, but the symptoms people see every day. So we'll be really pushing this campaign once we have these modules up and running for as many GPs to be doing this as much as possible. Ideally, we would love our own screening test. There, it's all very variable about how to actually diagnose a NET. Some GPs send patients to gastroenterologists. Some get sent to all sorts of different specialists. We know from dermatologists um, to psychiatrists. We do know that patients get sent to psychiatrists because sometimes GPs think it's in their head, the symptoms, which obviously is not beneficial to anyone. So we ideally would love a screening test, and what that looks like we do not know, but we will be looking at these modules about how to really at least push for an ultrasound, a CT scan as this first point of call, especially when the symptoms cannot be identified as put down to anything else. Um, as I mentioned, the referral pathways are really, really important as part of this framework, and we are still lobbying government even now for an optimal care pathway that is endorsed by all the state health ministers. So we have been told that this is on the table, but again, COVID has delayed a few things, so we will be completely pushing that through. But that will also feed into this national framework so that when you are diagnosed, you get seen very, very quickly by a multidisciplinary team. You get the best care and you get the best access to these treatments. So you're not spending months or years trying to find the best people, which again increases these costs to you, but also just, really affects our outcomes as well. So there's some of the key things. And very interestingly, we have such an argument to make now. On the Cancer Australia website, it says only that it's been updated just recently that over 4,900 Australians will be diagnosed with a neuroendocrine cancer in 2020. That's the estimations that they've made, and that's done through the Australian Institute of Health and Welfare. Well, if you break that down, we know that if you break that down, there's alpha paras, there's all sorts of different subsets there. But as a whole, that number is incredibly high. It's close to 100 people a week being diagnosed with a neuroendocrine tumor. So it goes again back to what I was saying about it's the cancer no one's heard about, but the one that's, definitely the symptoms that are seen every day, but also it is on the rise, and we know that. And it could potentially be because these diagnostic tools are in place now, and maybe it's more that than anything else. But that means that we have a huge argument to say that we need better care, better costs, better covering of costs, but also more investment in research. And that will again form a big part of this framework, is how can we in, encourage more investment in research in this area. We have very minimal clinical trials, ones that you guys have actually fundraised and paid for. Only today I was online for the AGITG, the Australian Gastrointestinal Trials Group update. It's their annual meeting. Unfortunately, we can't see each other face to face, but it was the online, and they were doing the update of the NABNEC trial, which was the neuroendocrine carcinoma, and the Control Nets trial, which you would be all aware of because you guys paid for it. And we're so proud of you for doing that. And it is recognised that, you know, without you fundraising and without our organisation fundraising, that trial would never have happened. And those results are really, really needed. So we need to work out with government how to, for our patients not to be paying for research, but how can government and also pharmaceutical companies be more interested in this area, because it is a huge area of unmet need. And I'll probably talk next week a bit more, but there just recently, last week, there was a Senate inquiry announced into exactly this, into access to novel treatments and drugs for rare cancers and disease of unmet need. So we fall into rare cancers as all different subgroups, but really we are a cancer of unmet need, because our numbers are so high. And we will be putting together a big submission to that, like we have in the past, but we'll really be looking again at all the different areas of the framework of what we can do there. So I really encourage you to please send me any evidence of especially the out of pocket. So I obviously take note of all the conversations that are happening, but anecdote that you know, anything that I can actually use, or testimonials I can use to really push this argument forward. Please know that anything you do supply, we do use, and we do use all the research that you all participate in to the best of our ability. And we have seen some really good wins, but we have so many more to do. So if you haven't, as I mentioned before, if you haven't signed up to the e-news, please do, because that's where we can try and get out as much of our information as possible. And that's just on our website. You can just subscribe through that. I did just put that paper up on the website too, if that's something that you'd be interested in looking at. But in saying that, we know we're living this, so I don't know that it will tell you anything different to what you already know. But what it does allow us to do is show other people and policymakers and decision makers what these costs are. I have put up there around the Senate inquiry, because we will be encouraging patients to make their own submissions, which I know some of you have done in the past and done really successfully, and we're really grateful for that. So I hope that, I know I'm not Kate, but I hope that I have been able to provide you with a little bit of an update. And as I mentioned, over the next few weeks, we'll be talking about what we're going to be doing around awareness, what we're going to be doing around research, and all the different other things that complement the support side that we try to obviously supply as well. So as I mentioned earlier, please, if you are having any difficulty cross-border access for your treatments, for your scans, for anything like that, please message me or email me at simone@neuroendocrine.org.au. And I'd really love to hear from you about that. But in the meantime, we will be working with Tasmania to improve the border restrictions there in the short term, as we have tried to do with our New Zealand friends as well. So thank you, everybody. Wishing you a very happy Friday and a lovely weekend. For our Victorian friends, we may see a glimmer of sunshine tomorrow. So enjoy your 1 hour of exercise, but stay safe and stay well, and please get in touch with anything you think that we can help with at all, and look after yourself. Thank you, everybody.